Welcome to the Healthful Woman Podcast. Today's Monday, March 8th, 2021. I'm joined today by Sara Kostant to talk about induction of labor, everything you need to know. Currently, about 25% of pregnant women in the U.S. undergo induction of labor, and that number's on the rise. Sara and I talk about why we might recommend an induction and what our thought process is in coming to that recommendation. Also, for anyone who is scheduled for an induction, we go through the process step by step to give you a sense of what to expect. I have found that the process can be a lot less anxiety-provoking when women have this knowledge up front. On Thursday, our high-risk birth story is a really powerful one. I'm going to be joined by Julie Mafuda, who's going to tell the story of her delivery in the height of the pandemic. Next week on Healthful Woman, I'm going to be joined by influencer Fortune Duche to talk about influencers and wellness. Reminder, we're going to have a Healthful Woman podcast every Monday and a high-risk birth story every Thursday. So be sure to subscribe to both. And if you're on Apple, we would really appreciate you giving us a 5-star rating for both podcasts. Thanks for listening. Have a great day. Welcome to today's episode of Healthful Woman, a podcast designed to explore topics in women's health at all stages of life. I'm your host, Dr. Nathan Fox, an OBGYN and maternal fetal medicine specialist practicing in New York City. At Healthful Woman, I speak with leaders in the field to help you learn more about women's health, pregnancy, and wellness. Sara, welcome back to the Healthful Woman Podcast. So nice to see you.
Yep, good to see you too.
Fantastic. So we're going to be talking about induction of labor, which is really common, and we're going to cover what it is, why we do it, how it's done, but also be kind of practical for our patients, what to expect with an induction of labor, because I know a lot of people heading into it have a lot of questions, and it's uncharted territory for them. And a lot of them are actually tuning into this podcast just to hear what it's like.
Absolutely. We were talking last time I did a podcast. We need to do something pregnancy and labor related. I covered pre-pregnancy, post-pregnancy recovery, and now we're actually getting into the delivery.
We're working our way towards the middle of pregnancy.
Right, exactly.
So for induction of labor, essentially, it happens a lot in pregnancy. It's pretty common. Every practice is a little bit different, but in the US, I think like 25 or 30% of women who are pregnant ultimately get induced at the end of pregnancy. And I'm not sure if people are aware of that. Do you find that people are surprised that they're getting induced?
Actually, I find more patients almost expect, and again, this does vary city to city, practice to practice, but I feel in our practice, many patients feel like most likely they'll tell me I'm probably going to end up getting induced. And I'll kind of ask them why. And I think a lot of it is, it for a variety of reasons that we'll kind of touch on. Right. It has become more common. And when patients talk to, let's say, friends or family members, I think they just hear about it.
Right.
It's almost the expectation and in particular in our practice, we do have a more higher risk patient population that has more medical issues. So I think for that reason, a lot of our patients, kind of feel that at some point, like when I talk about timing of delivery, some patients will even be surprised when I talk about, usually if everything's going well, we, maybe like a week after your due date, if you haven't gone into labor, we'll have you scheduled, or, we'll talk about an induction, and they'll be like, wow, I'm going to go that far in the pregnancy.
Some of them are not only shocked and surprised, and some are quite dismayed
by
that.
It's like, I didn't want to be induced early, but I didn't want to go that far.
Yeah. And I think part of it is because of the reason someone would get induced. And I think a lot of the time people's perception is, oh, the reason I'm getting induced is because, well, enough is enough. And the doctor's like, we're through with you and you've been pregnant long enough, or it's more convenient for me or more convenient for you. And actually, that's not why we do it. It's almost never why we do it, actually, in our practice. And it's really, we're trying to balance the risk of staying pregnant versus the risk of an induction. And that's a complicated, calculus. And so in our practice, since we tend to have more higher risk patients, there can be risks with an ongoing pregnancy, either to the mother or to the baby. And that's why we're more likely maybe than others to recommend an induction. But again, it's not just because, like, we're usually, giving a reason for why we're doing it.
Yeah. And that's one thing I also stress to patients is that, we're a larger practice and we have a 24/7 call schedule. So we really base the decision on what's best for the patient and her baby. I don't tell people, oh, you need to, or I'd recommend you be induced on Wednesday night because I'm there the next day. And
Right.
I never do that. Some patients will say if they need to be induced, they'll want to maybe be delivered on a particular day if there's someone that they want to deliver with. But we really focus it completely on what's best for the patient. And usually when I talk to patients also about induction, even if it's for a medical reason, we give a range of time. Like it won't just be, okay, this particular day. We'll say, anytime from, let's say, like 39 weeks to 39 weeks and 6 days. So it does give at least some range of time for the patient to figure out what's best for her. But yeah, I don't push patients into induction just because of any convenience on our part, definitely.
Right. That's a good point that, in practices like ours, and many are structured that way nowadays, since there's always someone who's assigned to cover labor and delivery, and that person gets relieved by someone at a certain time, it's not like, people think, oh, I have theater tickets and therefore I'm inducing you, or I'm going out of town and therefore I'm inducing you. It really doesn't work like that. It's we're there every day. One of us is there every day. So it doesn't really matter for our schedule. It's much more so for the patient. And when we're trying to think of risks, I mean, there's a couple of big ones to staying pregnant. And the biggest one, which is, the hardest to talk about only because it's so scary, is the risk of stillbirth, right? With every pregnancy, as it progresses, there is a small risk of stillbirth, of the baby passing away inside. Now, again, it is small, but as you get more pregnant, particularly when you start passing your due date, that risk starts to go up a little bit. And if there are other risk factors on the table, twins, high blood pressure, diabetes, other medical problems, the baby's not growing so well, the fluid is low, whatever it might be, that percentage starts creeping up to a number that it gets uncomfortable.
Right.
And you're like, we can wait and, most likely everything's going to be okay. But we really try not to use most likely when talking about the health of the baby. And so based on the risk factors and based on the circumstances, our break point for when we're more comfortable delivering than waiting changes. And sometimes it's a week after the due date, like in the lowest risk of pregnancies. And sometimes it's at the due date. Sometimes it's a week before the due date. Sometimes it's 2 weeks before the due date. And so different people are going to get different recommendations for induction based on their specific circumstances in their pregnancy, both their risk factors and how things are going along for the baby.
I would say what you mentioned, the risk of stillbirth, as uncomfortable it is to talk about, is what drives some of this, most of the decision making regarding induction of labor. And the one instance that would also, as from a maternal standpoint, from the mom getting sick, is women with high blood pressure or women who develop preeclampsia. There's a risk to the baby, but there's also actually a risk to the mom to staying pregnant longer, because preeclampsia is something that can be very dangerous for the mom. So in a woman, let's say, who has well-managed chronic hypertension, comes into the pregnancy with it, but her blood pressure stays normal throughout the pregnancy. Maybe she's on a medication during the pregnancy and everything's going well. There is a point where we will say, we, even if things are going well, we don't recommend going past this point in the pregnancy, not just because of risk to your baby of stillbirth, but also risk to you, because if you get preeclampsia, that could make you very sick and that could be potentially life-threatening for you. So there are some issues that we will recommend induction for that are really just related to the risk to the baby. But that's one instance where it's also related to the mom's health as well.
Right. And I think it's important for women who are getting a recommendation for an induction of labor and they don't really understand why, or maybe they're not comfortable with it or even opposed to it. It's important to speak to your doctor and say, why are you recommending this? I mean, what is it that you're concerned about that is making you recommend an induction and to sort of, quote unquote, end the pregnancy at a certain point in time? And you may end up hearing something, well, I'm concerned about stillbirth, which can certainly be freaky to hear. But you may hear something like, well, it's for your health or whatever. And I think it's important to get that understanding, because when people, talk about induction, they often even don't understand what's going on and why it is. But typically there is a good reason for why it's being recommended. And the only reason you may not want to talk about it is if you just don't want to talk about the idea of stillbirth because it's just too painful to think about, which is understandable, which is also why we try not to just drop that on the table towards the end of pregnancy, because there has to be some, art in bringing that conversation up without scaring people too much. But if you don't know why it's happening, just ask and your doctor will be able to tell you.
I'll look up and bring up statistics specifically just so patients can understand when I say there is an increased risk of something. Some patients will ask, okay, well, like what's the degree of increased risk? And I'm happy to actually, show the numbers. And for some patients, they're like, okay, that actually makes sense to me now, as opposed to just saying that, it's just an increased risk. Some patients I'll bring it up and they'll say, okay, fine. Like that's totally,
right.
Especially, some
and they're
patients,
happy to be done.
They're like, thank God, great. 39 weeks, 38
right.
weeks, if there's a medical issue. But there are some patients that really, they understand that they may be higher risk and we're recommending delivery at a particular time. And we'll again go into this a little bit more, like they really wanted to go into labor on their own. And so for them, I think it's a little harder to, go along with the idea of an induction. And it does take explaining, even if the patient knows that she has a medical issue and suspected that this would be the case.
When you and I were training, there was this rule in obstetrics that if you induce someone's labor, you are increasing the risk of a cesarean. And because of that, we were very hesitant to induce people unless it was absolutely necessary, because we don't want to increase the risk of a cesarean. And that is definitely the thought amongst women, amongst, the lay press, amongst pop culture, amongst online, whatever it is. But what's interesting is in the past few years, a massive study was published showing that that's not the case. And if you look at women at 39 weeks and you induce them versus not induce them, the C-section rate is exactly the same. And we've discussed this in other podcasts and why that is. And essentially, it's because the older studies were not well designed. They compared people being induced to people who were already in labor, which is unfair, right? Because if I'm deciding whether to induce someone, the alternative to inducing her is not she shall be in labor. It is, we're just going to wait.
Right.
And when you wait, she may go into labor. She may end up getting induced a week later. Something might happen. And so when you do this study properly, there was no difference. And it's been shown in other populations, in women with hypertension and women with ruptured membranes and multiple populations of women. It does not make a difference in terms of C-section rate. Again, provided that you are patient and let things happen. So it's removed some of the concern for induction of labor, certainly amongst the doctors. And I think it's trickling down to the women as well when we explain to them that, no, we're not increasing your risk of a cesarean, because that's typically one of the biggest hesitations there is.
That's probably the number one hesitation that women bring up to me whenever I bring up the idea of an induction is, I don't want to end up with a C-section. And I bring up that trial, which is known as the ARRIVE trial, interestingly enough.
All big studies have to have a fancy acronym.
Yeah.
That's the rule.
And it always has to kind of match the goal, like what the trial's talking about. It's like ARRIVE. Yeah, I'll bring that up and I'll go over with them that the reason why I think that that's the case is that when you induce someone and you give the induction the time that it deserves, and you're familiar with how much time each stage of labor is supposed to take, then the induction itself should not increase the risk of a C-section. I think that they're probably, and a lot of this is what patients have heard from friends and family is, in the past, I think sometimes if an induction was taking a longer period of time, sometimes some physicians might have said, well, it's not going anywhere, and kind of ended things a little sooner. And I think, I'll hear from patients who will say, my friend delivered, or when my mother delivered us, and they'll bring that up, that they hear these stories about how, at a certain point in the day, it's like, okay, we're not continuing. And so I reassure patients. And again, I think that in our practice, because we have a call schedule, we have our, we're on call to a certain point, someone new will take over that also knows the patient, but there's the deadline. If we even set a deadline, only has to do with the mom and the baby's well-being. And it's a point where we say, look, if we haven't progressed past this point, we're not going to get anywhere, and there's actually risk to continuing, as opposed to, it's a certain time of the day, we expect things to have been done by now, and if it's not, like, that's it. And we actually give more time than patients expect to inductions.
Yeah, and it's really important because, again, in this study, they were patient, and so it really is only applicable if you are also patient as doctors. And because meaning, yes, if I induce people and say, all right, it's been 8 hours, nothing's happened, let's do a C-section. Sure, you're going to, do C-section on 50% of people getting induced. But if you're patient, it really doesn't happen. And if ultimately an induction leads to a cesarean, that's likely what would have happened anyways, 5 days later when she went into labor, or a week later when we had to induce her
Right.
for another reason, or whatever it is. And I think that that's important. But it does bring up one of the downsides of induction is that it takes a long time.
Yes.
And that's really important for people to understand that, when you come in labor on your own, you've hit the ground running, right? Most people, when they show up in labor, they're contracting regularly and painfully. Their cervix is 3 or 4 centimeters open or more. Their water may be broken already. They're booming. And that, to get to that point, could be 6 hours at home, 12 hours at home, 3 days at home. It could be anything. And when we're inducing, we're taking that period, that 6, 12, hours, 3-day period, and condensing it into overnight.
Yeah.
And so it takes more time to get to the starting line, so to speak. And that's why inductions frequently will take 12, 18, 24, 36 hours, whatever it is. And that's important for people to know on the front end.
That's the one thing I will always acknowledge to patients about induction is, and I will admit to patients because they'll bring that up too. And I will tell them that is true. Just to get you to the point where you're starting early labor will take several hours. And sometimes during inductions, I'll actually offer it as a point of reassurance, though, that some patients will say to me, I'm 3 or 4 centimeters. I was hoping I would be more dilated. And I'll say, actually, I wouldn't have expected things to have progressed past this point. Like, you're kind of exactly where you should be. So that is one disadvantage. Again, for medically indicated induction, the benefit is still going to outweigh that for many people. But it's something I bring up if someone does want to be induced a little like earlier, and we'll talk more about that.
Right.
That's the one disadvantage I'll say, is that you will just have a longer time in the hospital, and the process of just getting you into labor may take longer.
Yeah, and I think what you're getting at is this idea of this elective induction, if people just choose to be induced. And there's actually new debate about whether we should even be calling it elective induction. Because again, if you're after 39 weeks, there really isn't any known benefit to the baby to staying inside longer. Under 39 weeks, there seems to be benefit. And the earlier you are, the more benefit there is to the baby to staying in. But after 39 weeks, that sort of peaks. And so the thought process is, well, since induction does not increase the risk of a cesarean, and there's some risk of stillbirth, it's not really elective. You're inducing for the same thing we said before. You're taking sort of, a very low risk of stillbirth and saying, well, fine, I'll induce because there's not an increased risk of cesarean. And so for that reason, some people aren't calling any induction after 39 weeks elective anymore, like just by choice, patient choice, doctor choice, whatever. And I think that's true, but ultimately there is some issue with that, because if every single person got induced at 39 weeks, you're essentially doubling the time someone's going to be in a labor room, and there may not be enough labor rooms, and then you're going to have people showing up and, delivering in a hallway or whatever because there aren't enough spots. And there is a logistical concern to that. But I do agree that the idea of getting induced after 39 weeks should not be one of like shame that you're doing something, purely elective and it's a bad idea. It's fine. It just takes longer compared to doing it spontaneously. And so we tend to do it only when there's other risk factors, only because they wouldn't get a spot at the hospital. Like there just wouldn't be one available, even if someone wanted to get electively induced at 39 weeks, because all the other people waiting to do it would take priority over her.
Yeah, I agree. I think that my threshold for offering induction starting at 39 weeks, where there's not, as you were saying, like a medical indication of the sense of like high blood pressure, or diabetes, or low amniotic fluid, I have a much lower threshold. I'm to discuss that and offer it, which is again such a change from residency, where it was like actively discourage patients from even considering it. I don't do that now. We both have patients that will bring up concerns about going past 39 weeks, either logistically that they live very far away, they're worried that their labor will go quickly, that they're extremely just uncomfortable during the pregnancy. All things that as a resident we were still kind of taught, well, encourage patients to not get induced unless again there's one of these medical criteria. And now I feel very comfortable bringing up, we could arrange for you to be induced once you cross 39 weeks, as long as everything stays okay. If you have concerns about getting to the hospital on time, if if someone's worried that their labor is going to go quickly, if they have had a lot of, just chronic pain issues, flaring up in the pregnancy, sometimes even for those, we may, need to induce patients earlier. And some patients are surprised actually that that's even an option. So I think it can be a good option for many patients, especially, and if someone has had a baby before, the induction would probably go more quickly. But even someone who's never delivered before, is 39 weeks and is, wants to discuss induction, I'm, I think we're fine with it. And as long as we can find a spot at the hospital, and as long as the patient just understands that the time it may take to have a successful vaginal delivery, we'll be there and we'll do it.
Right. And we function under the constraints of our hospital, like everybody does. And like you said, if we're there every day.
Right.
So for us, it's not inconvenient or convenient for someone to get induced. It is like, it's fine. But at the hospital, there's a lot of people being delivered. And if, there's 5 people getting induced that night, all of whom have a stronger reason than, our patient, she's going to have to wait, essentially. And I explain that to people also, that we're okay with it, but just, we have to operate, under the constraints of our hospital and volume. And that's true everywhere. It's not unique to where we deliver. And under 39 weeks, it's a little bit, there is a higher bar because, again, like we said before, there is some upside to the baby to waiting to 39 weeks. So if there's no reason whatsoever, we're not going to typically induce before 39 weeks, but there are many medical reasons for the mother or baby that we do deliver under 39 weeks. And again, it's just a matter of, it's the same idea that we're balancing, but the bar is going to be set differently when you're under 39 weeks because you are potentially increasing risk to the newborn by being either premature or mature, like term, but less term. And so you really have to have a good reason to induce beforehand. And that's been a big push in the past several years for good reasons, to not induce people for sort of mediocre reasons prior to 39 weeks.
Yeah, many patients are surprised because they'll know that 37 weeks is what we consider term.
Right.
But even at 37 weeks, some babies that are delivered, even if it's just spontaneous, labor, like mom goes into labor, delivers, some occasionally will have some breathing issues, or some issues with jaundice or feeding, very mild, and those babies usually do very well. We don't expect any long-term issues. But after 39 weeks, the risk of that pretty much is eliminated. So between 37 and 39 weeks, if someone otherwise is doing fine, there's no reason to induce. Well, we won't. Obviously, if there's any issue that could pose a risk to the mom or baby, we'll go ahead. But that's why if things are otherwise going well, 39 weeks is really what we try to get to, especially if there's really no medical issue.
Right. So we spent a fair amount of time talking about sort of the concept of why someone would get induced or get recommended to be induced, and sort of our thought process of why we would recommend it versus our hesitation, and how we decide who needs it and when to do it. And that's all very important. And I want to shift now to sort of the second aspect, is just, how do we do it? Like, what is it that we do to induce labor? And then the third part is sort of what to expect, from the patient's perspective. So in terms of how we do it, the way I try to explain to people is, when someone is going into labor on their own, there's a slow process where the cervix over time softens, shortens, opens a little bit. And at the same time, the woman's going to have contractions that are getting closer together and getting stronger. And they don't always happen at the same time. Sometimes she's contracting before the cervix opens. Sometimes her cervix opens before she contracts. Sometimes they happen simultaneously, but it takes a while. And the point of the induction is basically to take someone who none of that is happening and to get her to cervix open, contracting, artificially.
Yeah.
And there's different ways that we can do that, but all of them require something. Right? We have to either give a medication or do something physically to the cervix. So what are the options that we have to induce labor?
The first options are kind of in the category of what we call cervical ripening agents.
Right.
And we use these for our patients who come in who have a cervix that is closed and fairly thick, which is, I would say, most of our patients, especially if they've never had a delivery before. Probably the option that we use the most, which I actually like the best for a number of reasons, is a cervical balloon. And what we basically use is it's like a thin rubber plastic catheter that you place in the cervix while I'll do it, or one of the residents will do it while they're doing an exam. And it's placed into the cervical canal. And then there's a balloon at the tip that's inflated with usually water or saline. And mechanically, as it's being inflated, as you can imagine, the cervix is a fairly pliable, softer structure. So when the balloon is inflated, it will push open the cervix. And we leave that balloon in as long as it needs to stay in to just mechanically open the cervix. Now, we're not trying to have someone go from closed to 6 centimeters with this balloon. The balloon fills only to a certain point.
Right.
And I would say by the time it slips out, by the time it's dilated the cervix enough, the cervix might be 2 or maybe 3 centimeters dilated. The other thing that the balloon does is it will trigger the release of certain chemicals in the cervix that may also help further soften the cervix. So our goal after placement of the balloon is that by the time it falls out, which can be anywhere from, I've had it fall out 20 minutes later, I've had it take 6 or 7 hours. Most people, I would say it's probably in for like 2 to 4 hours before it falls out. The goal is that we now have a cervix that's maybe 2 or 3 centimeters dilated and a little bit softer and ready for the next step in the induction process.
Right. I mean, essentially, it's the balloon at the tip of this catheter is about the size of a golf ball, give or take. And it's actually the same catheter that we've used for a long, long time for urinary bladders. It's called a Foley catheter. And the concept is when you slip it in, it's nice and skinny, and then you can inflate this balloon from the outside, but the balloon inflates on the tip all the way at the other end. And so you put in this thin catheter, inflate that balloon, and then when you put it on tension to like pull it out, it slowly gets pulled out of the cervix. It's like pulling a golf ball out of a cervix, basically. And so by the time it comes out, like you said, the cervix is open to some degree and usually softer, and frequently she's started contracting a bit as well, but it takes time. And you were going to probably go into some of the other ways you can get the cervix to soften and open for induction as well.
Yeah, another effective way, which I've also used in the past, is there's a medication called Misoprostol. It's also known as Cytotec. It's actually a medication that used to be used or still used for stomach ulcers, obviously in non-pregnant patients, because it was also found that it helps soften and dilate the cervix as well. When we use it, it can either be taken by mouth or it can be placed actually in the vagina. And it's just a pill, or rather even a piece of a pill, because the pill will be cut up into small pieces. And every 4 hours, it can be placed in the vagina, and then it gets absorbed, and it will help the cervix again soften and dilate. I tend to find it most helpful if a woman's cervix is so closed that I couldn't even place a balloon in her cervix. The reason I try to use the balloon, and again, this really varies from place to place, and there's no right or wrong answer to this, but I tell patients I like using the balloon because there's a little bit less of a risk of a patient having almost too many contractions. With the Misoprostol, it can be very effective, but some women are very sensitive to it, and once it's placed, they'll go from not contracting to sometimes contracting every minute. I've even had to give medication to reverse the contractions. So a lot of patients will actually ask about it because to them, because it's more of a pill, they actually request it. And I'll explain to them the reason why I prefer the balloon. And if a patient really, didn't feel comfortable having the balloon, we could talk about it. But I think a lot of patients see it as, it seems like a more gentler option, but and again, it can be very effective and very helpful in many cases. What I always tell patients is that the one downside to the Misoprostol is that it can sometimes cause what we call hyperstimulation of the uterus or too many contractions.
Yeah, I agree. And when I was training, we did the Misoprostol for everybody.
Mm-hmm. We did too.
Every 3 hours, as the intern, you're just going around the floor, putting them in, midnight, 3 a.m., 6 a.m., and you're doing that. And it's fine. It works. I find that the balloon, I prefer the balloon also. And I find that number one, I think it's more predictable. Right, the Misoprostol, sometimes you put it in and 3 hours later, they're off to the races. And other times it's you keep putting them, and you're not really sure what's going on. And I find that the balloon, even though there is a range, like you said, it's more predictable. For most people, it's going to be out 4, 5, 6 hours. And then at that point, since their cervix is open, you can do phase 2, which is break their water, which is really the next part of the induction process. And I also agree, it gives you some more control. You don't have that stimulation of the uterus to the same degree. You don't have that same risk of the contractions happening. If there's an issue, you can just deflate it and remove it. Whereas once the Misoprostol's in, it's in. Nothing you can do about it. And so in our practice, we use the balloon probably 95% of the time. Like you said, there's the occasional patient who we just can't get the balloon, his cervix is too tight or it's too uncomfortable and she doesn't have an epidural or doesn't want one or whatever. But most of the time it's a balloon and it's well tolerated. It's quite effective because once it's out, we can give Pitocin. So she's contracting. That's an intravenous medication to start contractions. We can break the water. And then since the Pitocin is intravenous, we can titrate the dose to give her more contractions, or we can back off to give her fewer contractions. Whereas the Misoprostol, it's all or none. You put it in and then it's
Right.
there. And so I find it's a little bit more user friendly, and I prefer it as well. And so that's what we do.
No, I agree. And as far as the comfort, the one disadvantage which you mentioned is just to put the balloon in. I have to do an exam, check how dilated the cervix is, and then place the balloon in. And many women, if let's say someone doesn't have an epidural, they'll feel maybe a little discomfort from the exam, and they may have some cramping, right after the balloon is placed, because it can sometimes stimulate some cramping. Again, many women tolerate it very well. A whole other topic is just, epidural, when to get an epidural. And some patients will ask me about that. And we do offer patients the chance to get an epidural even before the balloon is placed, if they just want to be comfortable and sleep through the rest of the night, especially if they were planning on getting an epidural at some point anyway. But I don't tell patients that they have to. And some women, even if they think they'll likely get an epidural later, they still like to defer it and wait, just because that way, at least, they can still, get out of bed, even with the balloon in. It's taped to their legs. So they could get out of bed if they want to just stand or stretch or, walk around a little bit. So I leave that up to the patient. I'll tell them, look, this is probably what it's going to feel like. Most people tolerate it fine. You have the option of getting the epidural, but you don't have to.
Right. I think there's two important things you said there. The first is that from our standpoint and from a medical standpoint and from a labor standpoint, it doesn't matter. Meaning if she's gets an epidural before we do anything to her, if she gets an epidural sometime in the middle of this, sometime later in labor, or not at all, it's not going to change when she delivers or how she delivers, right? The epidural does not have an effect, A, if she gets it or doesn't get it, or B, when she gets it. And so that's very, very important. I mean, the decision that she's making about the epidural is only what she prefers. And so in New York City, 90% of women plus get epidurals. Some don't, and that's great. And they don't have to if they're getting an induction, but it might be more difficult because, again, it's a longer time and you're not, at home doing something over many, many days. You're sort of compressing that into 6 hours. And so for many women, it might be more uncomfortable than spontaneous labor, only because, again, we're sort of like hitting the gas quickly. Yeah. But it's up to her. And I tell women the same thing. If she wants an epidural before we start, great. We can put in the epidural, then put in the balloon. Since we usually start at night, she can sleep potentially because she won't feel any pain. And then it's there for her labor, and that's fine. The epidural will last as long as we want it to because it's a continuous infusion. There's no endpoint on the epidural. If she doesn't want an epidural at all, fine, great, no problem. And if she says, I want one, but I want to wait till the morning, also fine. It's all good on our end. And so, and it's not a decision she has to make before she comes in. She can decide on the spot or whatever. Most people know if they're going to get it beforehand because they're going to, decide before we start, they're going to get it. But ultimately, it's not a decision that, quote unquote, matters in terms of her labor. It's really what experience she's looking for. Less pain, then she'll get it earlier versus she wants, to feel the contractions and have more mobility, then she'll wait or not get it at all, which is fine. In terms of the cervical ripening, so that happens. And then we were talking about before, after that happens, we really have to continue typically some medication so that she's contracting. Not always. Sometimes either the Misoprostol or the balloon will put someone into labor and then she's contracting on her own and we don't have to do anything. But I would say that's the exception. Most people will end up getting Pitocin, which is the sort of commercial name for oxytocin, which is basically stimulates the uterus to contract. It's the same thing that her brain makes naturally when she's in labor. But we give it intravenously. We give it on a pump. It's titrated. The dosing is very precise. We go up by a certain amount, so that it's safe. And we're just giving her the dose that gives her a normal contraction pattern, which is about every 3 minutes or so. Could be every 2, every 4, but around every 3 minutes. And the other thing that I always go over with women before an induction, particularly if they're doing the balloon, it's not just the balloon. It's the balloon plus breaking the water.
Yes.
Meaning people are like, oh, can you wait to break my water? I'm like, well, we can wait, but it's like literally putting the brakes on the induction. It's like a pause. And if you want to wait 6 hours in the middle, and do nothing, okay. but nothing's going to happen really unless you break the water, because it's the next step in inducing labor with that balloon. And that's a really important point, because some people hear otherwise, and they think that once we break the water that there's some clock that gets started and they have to deliver in a certain amount of time. And that's not true. It's just part of the process of inducing the labor.
It's a big topic when I discuss inductions. And I've also had some patients will request, not to break the water, to continue the Pitocin longer. And then I'll actually have some patients that will say, can you break my water but not start Pitocin? And so I've had both discussions with patients. The patients that ask about just breaking the water many times have had a prior delivery where their water breaks, and they'll tell me, I deliver 2 hours after my water breaks with
Right.
all of my kids. So that's a little bit of a different story.
Right.
But I'd say for the average patient who's coming in for induction, I do recommend both, and both simultaneously. We always we won't do anything without our patient's consent. So if I discuss breaking the water and a patient says, I don't want you to do it, I understand why you're recommending it, but I don't want you to do it, we will start or continue the Pitocin. But I do tell patients that it will end up prolonging their time on the labor floor, especially if it's a first baby. Usually Pitocin alone, even when we're, again, like you said, slowly increasing it, we're not trying to make the patient over contract. But often what breaking the water does is it helps the baby's head press down more on the cervix, so that when the uterus contracts, the head actually acts to push and help dilate the cervix. And when the water's not broken, even if the head is just, gently resting on the cervix, it's just not putting as much pressure, which is one of the reasons why the breaking the water can help. And also breaking the water helps even release more, chemicals that again can further soften the cervix and further help potentiate or just increase the effect of the Pitocin. I recommend doing both at the same time. I reassure patients, I explain how I break the water. I'll explain it's not going to hurt you or the baby. It's basically, it sounds kind of funny to say that, but it's similar to popping a water balloon.
Yeah.
That's basically what the amniotic sac is. And the fluid, some of the fluid drains out slowly. Not all of the fluid comes out at once. There's still fluid around the baby. Usually the baby's head will drop down, almost act as a little bit of a plug. And then as the cervix dilates more, a little more fluid will keep coming out.
I always remind people the reason we're doing this is to get you from not being in labor to being in labor, right? That's what an induction is, right? That's the goal. You're walking in, you're not in labor, and then we want you to be in labor because we're trying to, deliver the baby. And this is part of it. Breaking the water is part of that process. So someone says, I want to be induced, but I don't want you to break my water. I'm like, well, you're not being induced then. Like, we're just putting a balloon in your cervix and like, we're not doing anything. And so it's just an important thing for people to understand that it's like a package, right? To get someone in labor, we want to do it. And then if you draw it out too long, then you may be getting an extra 6 hours of Pitocin, which can have some, it's not that it's complicated to have more Pitocin, but there is a downside to getting more of it. And there's a downside to a longer labor in terms of risk of bleeding and infection. And so typically you want to do things in the most expeditious way that remains safe, right? You don't want to overdo it, like you said, and that's something that, we train to do. And, we sort of know how to do that. And that's important. And then once that happens, they're contracting, they're dilated, their water's broken. It's not markedly different from someone who comes in labor, other than it's a little bit slower. Like you said, their cervix is usually not so thinned out. It's still thicker. So, and you're talking from that point when their cervix is open, 3 centimeters or 4 centimeters, they're contracting regularly, and we break the water. It's very typical that it's going to take, 12 hours from that point till they deliver. It could be shorter, and that'd be great. But, so I tell people if they're going to come in at night, let's say at, 9, 10 at night, get an epidural or not, get their balloon placed around midnight and their water broken around 6 in the morning, it's not remotely unusual to deliver in the evening, 6 p.m., 7 p.m., 8 p.m. And that's fine. That's normal timing, and sometimes longer. They might get lucky and it's shorter, particularly, like you said, if it's not their first baby. But that's sort of the time frame that it's going to take. I tell people expect it to be up to 24 hours and sometimes longer from the time we start till the time the baby comes out.
Yes, I agree. And that surprises a lot of patients also to hear that even from the morning when their water's broken, it could still be not till the night that they deliver. But I'll tell them, but that's okay. Like, that's even if things are going well.
Right.
As for what a lot of patients bring up regarding, not wanting to have their water broken or being concerned about that, I'll tell them that we don't expect, it could really take 12 hours just, again, to get into active labor after your water is broken. And that means being like around 5 or 6 centimeters. And then from that point on, there still could be, a few to several hours before you get to be fully dilated, and then you're pushing the baby. And as long as, you remain, you don't have a fever, the baby's heart rate's fine, we can keep going. I think there is a belief that once you cross 12 or 16, I've heard patients tell me different things, but there'll be a certain amount of hours, like your water can't be broken for more than this time, or you have to have a C-section. But that's not what we use to decide whether someone has to have a C-section. If we broke someone's water as part of their induction process and they're otherwise making, what we consider reasonable progress. I mean, we've even had some patients go overnight of the next night. I would say that's not common. Like most people, if they're going to deliver, will deliver earlier than that. But we've even had patients who started an induction, let's say Monday night, and they delivered Wednesday morning, and they had a vaginal delivery.
Yeah.
And the baby did well, and they did well.
Yeah, we just had one last week.
Yes.
Right? Where,
I was just thinking of that.
Yeah, I mean, she came in it was a Wednesday night when you were on call.
Yes.
And then someone took over for her all day. Then Liz took over and was there all day Thursday with her, Thursday night. And then Friday morning, ultimately, Melka delivered her. You're talking, it was 36 hours plus later, and healthy baby, vaginal delivery, everything went fine. It was a little slower than typical, but that's okay. And again, like you said, we don't have like an alarm clock that goes off that says, oh, at X point you have to deliver from when we broke your water. It depends on the entire picture. How is she progressing? How does the baby look? How is she doing? What else is going on in terms of making that determination? And so people should be reassured that it's if they delay the water breaking, it's not going to give them more time or give them a lower chance of a C-section. It's really it has really nothing to do with that. What do you practically tell women, right? So they're about to get induced, or they're coming in that night or the next day. And so we went over, what the process is. They're going to come in, epidural or not, the balloon, the time. But what else should people know before they show up in the hospital for an induction, like in terms of preparation at home, or things to bring or things to expect that you tell women?
So I tell patients that are having an induction, because of the amount of time it takes, to really, to bring things that are going to keep them comfortable. The hospital will provide like basic necessities, like if you forget your toothbrush, forget your toothpaste, like they'll have all of that. A couple things that I've specifically started telling patients is actually to really try to get as much rest as you possibly can especially in the early part of the induction. So to bring some sort of eye mask just to block out light, and earplugs, just because once you're, admitted and settled in and the process has started, there's going to be a lot of downtime, especially in the early stages of the induction. So to bring that, just because, as everyone knows, hospitals are not the best place to catch rest. And even though many nurses will try to keep the room dark and, turn down the volume on certain monitors, it helps to have the earplugs and the eye mask. And I reassure patients also, you can definitely go to sleep. Like, we can see the fetal monitor that you're going to have on everywhere on the floor, because some women are nervous about sometimes falling asleep because they want to keep an eye on things. And I'll tell them, don't worry, we'll see what's going on with your baby. If we need to adjust the monitor, we will. Just, try to get as much rest as possible.
Yeah. And even in advance, if they're able to take a nap the day before the day they're coming in, before they come in, have a good meal, have a good shower. It's important to show up, as rested and full and just ready to go, because they're going to be there a long time potentially.
When you said have a good meal, that's another thing that I bring up, is that definitely before coming in, eat something that obviously appeals to you. I wouldn't eat something like, super heavy, but really there's no real restriction, but, just have like a good meal, because when you come to the hospital, you'll still be able to, have clear liquids to drink when you're at the hospital, and eating in labor is a whole other discussion. I know in our general practice, with some exceptions, is that when you're in the hospital being induced, that you can definitely drink whatever clear liquids you want, and clear liquids can means any clear juice, like apple juice, cranberry juice, vitamin water, even like a clear miso or chicken broth, black coffee without milk. All of those things are clears.
As Sam Bender says, clear liquids do not have to be clear, and they do not have to be liquids. Black coffee is a clear liquid and
Jello.
Jello is a clear liquid.
Yeah.
Yeah, it's basically
Sorbet.
it's basically stuff without dairy. That's a clear liquid, so no milk in it. The only solid food is something that usually is a liquid, like Jello. Then you gelatinize it. But like you said, vitamin water is good. Gatorade. If people like, seltzer, that's fine. Broth is very good. Black coffee, like you said, for the morning. If people are
Yes.
coffee drinkers,
Absolutely, bring it.
bring some nice black coffee with you, because the hospital coffee is also not very classy.
Yeah, I can attest to that. Any particular clear liquids that you think you would want that the hospital might not have, just, bring them along. And some of the reasoning behind this with induction is, I've had patients with a very long induction where, in the past I've said, yeah, go ahead and have more of a snack. But the idea is that we tend to refrain from that. And again, this definitely varies from place to place. Different hospitals will have different guidelines, but the idea is that we want to avoid as much of a full stomach as possible in case there was an emergency and a C-section was necessary. The idea is that if you've been drinking clears, the stomach is less full and there's potentially less risk of aspiration than if you had a full stomach if you've been eating the whole time. Again, this is a topic that there is some debate about, I'll definitely admit. That's at least the reasoning behind it, and policies change and things, ideas about this change all the time.
Yeah,
so.
the current hospital policy where we delivers, they don't want women having solid foods. That might change. Other hospitals is different. We don't make that policy.
Yeah.
We're just, we're following the rules.
Yeah.
But that's something, if you're not with us, you should ask about that. Say, hey, to wherever you're going to deliver, what's the rule on eating in labor? And they'll tell you what the hospital policy is for you. So yeah, so bringing chargers for your phone, for your I don't know, your laptop, bring stuff if you're going to get some work or you want to watch movies or you want to, do something or do emails, totally fine. Bring something to read if you prefer. Again, if you're going to be reading, bring your reading glasses. Like, these are things that people don't always think about. And it's not just you, but if someone's coming with you, if your partner's coming with, he or she's going to need all the same things, right? And they can eat typically.
Yeah, exactly. Snacks for the partner that you'll kind of guiltily eat.
When my wife was in labor, I had my bag. Snacks for dad. So I got my whole bag of food that I want. And also since it's a long time, we're in Manhattan. People can order food to be delivered. If it's in the morning, 4 centimeters, break the water, Pitocin starting, we're like, hey, maybe 10, 12 hours. If her partner wants to go get breakfast and come back. I mean, there's, as long as you're available by cell phone, different people feel differently about whether they want to be there the whole time with their partner or whether they want to come and go, or maybe they have, childcare to attend to at home. And, that can be individualized. But typically, since this is a longer process, it's not like coming in labor where you may deliver at any minute. We sort of can predict that unless something crazy happens, it's going to be a while. So there's a lot of options for coming and going. COVID throws a wrench into that.
Yes, definitely.
So if you're listening to this and there are COVID restrictions abound, something to ask about, whether partners A can come, B can come and go, how that works. But generally, in the world of the normal, partners can come and go and other people can come in, and doulas and other family members in and out. And so that's just important to remember in terms of planning your own induction.
Yeah, COVID, it's funny because the delivery services to Mount Sinai for food have definitely been booming in business because, at least at our hospital, and I think this may still be the case for now, partners, once they were there, could not leave and come back during labor. Once their partner delivered and they were on the postpartum floor, then they could actually come and go home and pick up stuff, and they didn't have to stay there for the full time. But and again, that that could be different in the next in a few weeks or a few months, and every hospital is also different with that.
Yeah, and that's important. And it's like the labor floor is like a secure unit, and the postpartum floor is a little more lax. It's one of these things with what is the level of acuity there and what's the space and the processes. And so it is a little complex to figure this out. So definitely ask in advance what's the most up-to-date policies for that. And it's also important, again, if you're going to have a support person in labor, like a doula, again, to ask her or him, what is the plan? Are you going to be there for the whole induction, for parts of it? Because again, the doula has to rest also. And these are things that just plan in advance, but all of it is based on the idea that this is going to be longer than if you just showed up in labor.
Right.
And a lot of the planning is for that. So there's the regular things you bring to the hospital, but then the extra planning because it's going to be longer potentially.
The one thought I had, just going back to earlier in the conversation, and again, this mainly has to do more with our practice and being higher risk, is that one thing I tell patients who are very nervous, who for a medical reason have to be induced, even like much earlier than they expected, is that, especially when they bring up what we talked about with C-section rates, I'll say, especially in your case, it may actually decrease your risk of having a C-section. Not even just that it doesn't change it, because if as a patient, if you have, let's say, again, hypertension, or especially any medical issue, which includes diabetes, lupus, anything like that, that may predispose you to getting higher blood pressure at the end of the pregnancy, being able to take our time to safely induce your labor means that we'll be able to increase the chance of you having a vaginal delivery, as opposed to when a patient, comes in and already has, let's say, severe preeclampsia, or the amniotic fluid around the baby is very low. Some of those situations, it doesn't mean that you have to have a C-section. We can still try to induce the labor, but the chance of a C-section gets higher because, if a patient's blood pressure is uncontrollable, we may not have the time to have them continue to have a vaginal delivery. Let's say we have a patient whose baby has been very small through the pregnancy, like exceptionally small, what we would call growth restricted, not just, small.
Right.
And there's some signs that the blood flow to the babies is compromised, or there's lower amniotic fluid. The longer we wait, the more likely, first of all, putting aside any outcome with the baby, that when we finally go ahead and induce labor, the baby may not tolerate the labor.
Right.
So I actually think that, again, it's all about finding a balance. We try to find a point where we can have a successful vaginal delivery. We're not going to be delivering the baby too prematurely. It's really a balance, but sometimes trying to push things off too much to further than we feel comfortable with the patient's medical state actually could just end up, they may not go into labor on their own anyway. And then when we finally induce their labor, may end up having more of a risk of a C-section. So I say that to just reassure patients that when we talk about induction, we're really in it for the long haul. We want you to have a vaginal delivery. That's ultimately our goal.
Yeah, it's a really good point that sometimes waiting, either the mother's health could deteriorate, or not the baby's health so much, but the placenta can start to deteriorate, which makes inducing labor harder because the baby, won't tolerate as well. And that frequently it's actually better to induce. And so these are the things that go into our thought process. And I think that's a really good point. Well, Sara, thank you so much for coming on and talk about induction. This is a very common conversation we have with women. And I think that this podcast will be really helpful, both for our patients as well as women, who are not our patients, who are potentially going to undergo induction, and maybe women who, underwent one years ago and are just curious about it and how it went. So thank you so much.
No problem. Thanks again.
Thank you for listening to the Healthful Woman Podcast. To learn more about our podcast, please visit our website at www.healthfulwoman.com. That's HEALTHFULWOMAN.com. If you have any questions about this podcast or any other topic you would like us to address, please feel free to email us at hw@healthfulwoman.com. Have a great day. The information discussed in Healthful Woman is intended for educational uses only and does not replace medical care from your physician. Healthful Woman is meant to expand your knowledge of women's health and does not replace ongoing care from your regular physician or gynecologist. We encourage you to speak with your doctor about specific diagnoses and treatment options for an effective treatment plan.